Welcome to Health Systems CIO's interview with Dr. Mustafa Yousif, Director of Digital Pathology and Assistant Professor in the Department of Pathology at Michigan Medicine. I'm Anthony Guerra, Founder and Editor-in-Chief. Dr. Yousif, thanks for joining me.
Thank you, Anthony, for your invitation. I appreciate that.
Oh, you're very welcome. All right, let's start out if you want to tell me a little bit about your organization and your role.
Yeah. So I'm Mustafa Yousif. I'm a pathologist first and informaticist, and as you know, director of digital pathology at Michigan Medicine. Mainly right now, we are doing a digital pathology transformation at Michigan Medicine. We started this journey about technically more than 24 months ago. And we are literally almost there. Next Monday, this Monday, we're going live with the first services for digital pathology.
All right, excellent. So you said it's been quite a journey, 24 months. Tell me sort of the beginnings of the journey. How and who decided that something needed to be different here? We want to digitize pathology. We want to move in this direction. What was the impetus? Why did this journey start?
Absolutely. So just to give you a feedback about the history at Michigan Medicine Department of Pathology, we already have more than 10 years of experience in digital pathology. But we were using digital pathology for consultation, archiving the consultation slides, teaching slide research. We did not go live with like as big to for primary diagnosis. We at the time of COVID, we went with couple of services or couple of faculty that they really need the needs for the to go live and sign out remotely. But other than that, we had like I believe we have three high throughput scanner at the last 7 years. And we have a couple of scanners we were using for quantitative image analysis. Mainly, we use it for ER, PR, HER2, and Ki67. And we've been using that system for the last 7, 8 years, I believe, to help our pathologists and standardize the biomarkers for breast biomarkers. So, uh, uh, 24 months ago, we started with a survey for the entire department to see how does digital pathology gonna help you, and if there is any need for the digital pathology, and what is your fear, what is your concerns regarding digital pathology. And we sent that survey to everyone, not just to faculty, but faculty, staff, trainee, and leadership. So we included everyone because we really wanted to understand the environment when before we build that system. We got a great feedback that majority are enthusiastic about the digital pathology transformation. Some of them, they say definitely they're going to use it for tumor board, for education, for research. Some of them, they say, I want to use it for remote. Some of them have really big concerns. And I'll be transparent. One of these concerns, like for example, I'm not sure if the transformation gonna go well. We heard from different institutions that images not appearing within timely manner might take longer time to distribute the image or longer time to distribute the glass slide. This is gonna slow me down. This is gonna right now I'm not comfortable of signing out digitally. So we really took all these inputs into account, and we started the process at that time and start investigating. To first thing that we did is how many shifts right now our labs. So we started with our histopathology lab, and we studied our histopath lab, and we wanted to know, the first thing is how many batches that our lab generating those glass slides. That's the first thing that we really needed to know in order to generate those slides or glass slide or images and distribute it. A lot of feedback and input from different institutions. They say, oh, it's so easy to redesign your lab to, for example, uh, generate those slides in the afternoon and start scanning overnight. But it's really easy said than done.
Mhm.
And what we did is our lab is 24/7. So it's really hard to kind of shift or change a shift so you can start scanning like in batches. So that was the first obstacle that we got, right? So the number of scanners, like how many scanners that we really need in order to be more efficient than our lab right now. The other thing is our lab really, really efficient because our department is really adjacent or within our histopathology lab. So the moment that the slide generated, distribute to our faculty. So there is no kind of delay of using different building or offsite location. The entire department for Department of Pathology is offsite. Within that location, we have the centralized histopathology lab to generate slides. So that is the first kind of obstacle we got. Then space, because you need a space to put all these scanners.
Mhm.
We start studying like where should we put these scanners, and we start like finding any place, location. Do we need kind of career to take all these slides to distribute it so we can put these scanners? That's another issue. The thing that I really want to share with everyone, we start having attending a lot of digital pathology workshop. Went to really high all these institutions that they already digitized their slides, and we start studying and learning from them. And we saw that they say maybe the best thing that maybe they, if they want to redo it again, to put the scanning lab within the histopathology lab, for example. Some of them have concerns because of it's a wet tissue lab, so you might have this wax and everything. But we've been scanning literally, as I said, within our legacy workflow, within our lab, and we didn't have these issues. So we put that into account, and we really start having like a huge renovation within our lab.
Mhm.
Put these scanners in the center of the histopathology lab. So you will have kind of efficient or seamless transmission from the slide going distributed to the scanner and then generate the glass slide. That is the first thing. Then the other thing is like how many slides that your lab generate for the per day, per month, per year, and what is your retention policy? That is what's also studied before we start anything. This is what we started. And our lab is generating about 2,400 to like 3,000 slides per day
Mhm.
in total. That's in-house, and all the we have a reference lab also. So because you really need to have a number of scanners to accommodate that images to distribute.
Mhm.
So, and then there are a lot of these kind of called image viewer,
Mhm.
right? Image viewer. Some of them they call it image management system. Some of them they call it case management system. You know, the other one is like virtual system. A lot of terminology in pathology that I truly believe that we should just go ahead and call it PACS, which to the audience, picture archiving communication system. I don't know why we're afraid, to be honest, of calling something like PACS. You need a system to organize those images, to archive those images, to retrieve those images. And that's a perfect, platform as PACS. So that's the other problem. Unfortunately, we don't have a lot of standardization right now within the pathology systems regarding the digital pathology. So we started investigating a lot. Although, like I'll tell you, before we went with our PAC system, we have literally multiple image viewers. We have an image viewer from our scanners, which each scanner provide different image viewer. We have an image viewer for our quantitative image analysis, because that one is different from the scanner that generate those slides. So a lot of, and then you need to make sure to interface all these image viewers together. So we decided to investigate in in a PAC system, a true PAC system that can accept most of the proprietary formats that these scanners generating right now. So that's the
Mhm.
first thing we did.
Mhm.
Uh, we went ahead and visit a lot of the headquarters. We tested almost every single scanner that right now in the market, either by inviting them to come to Michigan Medicine and test it for a couple of weeks or even a month,
Mhm.
or by going to the headquarter and bring our study sets and scanning those slides, because we really wanted to make sure that bringing to Michigan Medicine the best quality of those images. That's the first thing we did. We started with what's called RFI, request for information.
Mhm.
Okay. The request for information started by we just wanted to know what is available in the market. After that, we started with after what took all this information, we started a true RFP, request for proposal. And then for that request for proposal, our procurement team start communicating with all these vendors and regarding those, as you say, image viewer or case management system. And we kind of selected multiple of them. They came to us, we invited them, they did multiple presentations
Mhm.
regarding for the faculty, for the clinician, for and also let's not also we included the IT team. So we have a huge IT team that we included them because you want to make sure that from information assurance, security, all these are compatible with what you're going to bring to the department or to the institution. So we did all of that. So we have multiple presentation to faculty and to the IT. And then after that, we start ranking them. So technically, that's why when I said like it took us more than 24 to 26 months, because literally the survey and the RFP was about 6 to 8 months. Sometimes, it depends from different institutions, but for us, we want to make sure that, we're going with the book and everything. So it took us around 6 to 8 months to finalize the RFP and going with the project that we chose.
Mhm.
So yeah, so that's how we started, and we also started before the RFP, to be honest, as with the SWOT analysis. And as you know, with the SWOT analysis, we want to make sure that what is our strength, weakness, threatens, and opportunities regarding the digital pathology.
Mhm.
So we did that. We have a proposal. We started with a proposal with our leadership, and we provide that proposal to the enterprise because you need to have kind of backup or the support from your institution and from your leadership and from your department to start such a big project.
Mhm.
So this is how we started.
All right, very good. I am very interested, and you could take me from the beginning through the project. I'm very interested in the relationship between yourself heading up digital pathology and enterprise IT, the CIO, the CMIO, whoever your main partner was going to be on that side. Take me through that from the beginning. I
Yeah,
mean, when were they brought in? When did you start those conversations? What did you tell them you needed from them in the project? Did you need their support? Where did you need them to lead? Just
right.
tell me about that relationship.
Right. So in a simple word, I'm just not going to make it in really that complicated. So we started literally from the beginning. We included our colleagues from radiology, by the way, from day one, and including them to the table because we invited them. This is what we really need to build. Radiology have more than 20 years, over 20 years of experience in the digital imaging fields. So they are really ahead of us, to be honest. So we really need to learn from their experience and how can we make it better. So from day one, we included them. And really, I advise every single one. If you want to start your journey, you just started your journey, please go ahead and start communicating with your colleague, with your radiology team, at least in the beginning, to see if there's an opportunity of having a kind of what's called an enterprise imaging platform instead of being siloed. What is our problem right now in the pathology field? Unfortunately, if you go to most of the institutions, that pathology is still siloed It's still, that they build their server, they build their platform. But if you want to share that platform right now to any of your colleague clinicians, radiologists, they don't have access. And neither pathologists have access to their system. It's siloed. And that generates a huge problem because you need the support and you need to have to build all these servers from scratch if you are siloed. So we started the communication. We told them this is our plan, this is what we need. As I said from the beginning, we told them how many slides we generate, what is our retention policy, and what do we need, and in case if we are going into phases. From the beginning, we said that we're not gonna go kind of you know, all at once. We're gonna roll it out and service by service and phase by phase, just to make sure, because this is a learning curve for us, and we want to make sure that we're doing it right.
Hmm.
So the radiology team at that time, they told us that we have a PAC system that is capable of having pathology images within their system. And
Hmm.
a matter of fact, that they already have that system, for pathology in different institutions. So we went ahead and we visited multiple institutions that PACs have. Of course, we included them in the RFP also, and we start the evaluation. The other thing is, uh, all images from Michigan Medicine is stored in a centralized data center.
Hmm.
So we are, again, this is not, again, not siloed. So if we, like in the future or right now, we try to store all these images, it's all within the same centralized data center. So how did that help us? It helped us in many things. Every time we need to upscale our storage, we just need to have a request. Of course, you need to support. Of course, you'll think like either your department or your institution is gonna support that, the funds for it and secure the funds. But it's already been there. You just need to upscale the storage if you need it. Same thing with the servers for the platforms. Like if they already have that platform ready, already everything is built from security, information assurance. You don't need to build this entire system again from scratch. And what we did, to be honest, because we went with an enterprise imaging solution, I'm not exaggerating, but it really cut, like we saved around 12 to 18 months of implementation, minimum 12 to 18 months, because in order to do that, I have to hire more expertise, especially from the IT team, to build that system if it's going to be siloed within just pathology. And instead of that, we literally use or leverage all the expertise and also the storage and the servers that's already been built.
Hmm.
So that was really something that we really gained from going with enterprise imaging. The
And
other
you, excuse me, but so you went with a system the organization already had, and I believe you said it was being used in radiology.
Yes, so the radiology being already went like more than 3 years ago with that
Mm-hmm.
system, already being already using that system more than 3 years ago for that PACS. That's correct.
So that was very important. You had discussions, you were able to find out what was already owned by the health system, what was already being used, and that saved you a lot of time and a lot of work. So that would be a lesson there for your colleagues. Find out what the organization already has, have conversations with radiology, with your enterprise IT folks, and discuss with them your goals and what you want to do, and they may come to you and say, "Oh, by the way, we have this. We have these tools already. You're way ahead of the game."
That is exactly right. Right now, literally different institutions, they're coming to us, they say, we have this system already built. Do you think maybe we can use it? So there is another institution that I was trying to convince them to use the pathology imaging. So they told us right now they are going to work on it and they're trying to build that system in pathology. But I told them, guess what? You support more than, like, I don't know, 600,000 of these images for that institution. So you don't want to lose that opportunity in case if you want to go as an enterprise imaging to another vendor.
Mhm.
You literally you have everything ready. You just need to build that viewer or
Mhm.
that system in pathology. But
Mhm.
I'll tell you what did we do also. Another thing like enhance this PACS experience. Every single image right now we are generating at Michigan Medicine from pathology is DICOM format.
Okay. Yeah.
So that really, really, really make a huge difference. Why? Because right now you have a lot of these pack systems that only support DICOM, which is fine, but they really need just to support also add to into it to support DICOM pathology or what's called slide microscopy
Mhm.
modality for pathology, which is the
Mhm.
whole slide microscopy regarding the DICOM format in pathology. So
Mhm.
imagine if you just they invest and they start supporting DICOM, they
Mhm.
can right now receive any of these images. And right now, it doesn't matter from what scanner. There are some literally kind of misunderstanding about like, hey, I need to buy this scanner because I only like this VR only work with this scanner. I don't care anymore.
Mm.
Literally, some people like right now they say I have this viewer, but unfortunately I can't buy this scanner because this viewer cannot support this format. I told them I don't have this problem for me as long as the scanner generating and a DICOM format, I'm good. But also unfortunately, not every scanner is capable of generating DICOM format. So what did we do? We generate what's called dichomizer.
Mhm.
So even if a scanner right now not generating a DICOM format, we have a dichomizer to convert the proprietary format into a DICOM compatible slide microscopy in pathology.
Oh, nice.
So right now, literally every single of the high throughput scanners from Michigan Medicine in pathology, we're sending DICOM. And this can also help us if you want to send in images to
Mhm.
any institution, like for example, to transfer patient care, have any consultation. It's going to be so easy. Why? Because it's a standardized image. They don't need to worry about the problem that are they going to be able to read those image or not. So
All
that's
right. So
sorry.
so let's take this scenario. At another health system, you have someone in your position who's heading up heading up pathology, let's say, and they want to go digital, right? They want to, what you did 2 years ago, or the initiative you had, they want to make pathology digital. They want to digitize pathology. And they need to have discussions with enterprise IT. They need to, right? At some point, you need to engage enterprise IT, the CMIO, or maybe you go to the CMIO first. Maybe you go to the CIO. What would your advice be to that person in terms of engaging enterprise IT? What do they need to say? Because enterprise IT is not going to understand the nuances here. They're not going to be familiar. You probably have a CMIO who is not a pathologist, right? In most cases, the CMIO is not going to be a pathologist. Obviously, he'll be a physician, but he may not be a pathologist. So, a lot of times, in order to really support a department, the IT individual has to understand the operations to some degree to
Correct.
that they can help you better, right? If they understand. So there may be a degree of education that you have to do, educating them on exactly your workflows and the technologies you do have, and then say, here is where we want to go. Can you help me? Can you support me in this journey? Tell me about that.
Exactly. Exactly right. So there are a few things that the first thing I want to clarify, we've been really fortunate that we have an entire pathology informatics department, and the director, Dr. Yul Belize, is director of the department, and also he's the ACMIO, so he's associate CMIO. At Michigan Medicine, we have the CMIO, and then underneath him, we have a lot of associates,
Mhm.
main of these associates from each department, like pathology, radiology, and other ologies right now. So we didn't have this problem for us because we have the knowledge. Like I'm also informaticist, and when we communicate, we know what do we need from our end. The most important thing is you have to study, just like what I said in the beginning. you really have to study your lab. Make sure that what do you need? Are you going live with everything? Are you going live with selected services? How many slides that are you planning to scan? And the most important thing is try to make sure that what are you trying to digitize. These are things are so easy. And then things like when it comes to the like the file format, the scanner, these things, they may also the radiology department or the IT department can help you with that. That's also. So I'll give you one example. Like, are you trying to scan every single bright field? But what about your immunofluorescence? What about your electron microscopy? What about your gross images? Sometimes also in the same department, you have the whole mount versus standard slide size. All these you need to make sure that, because every slide or each modality are different and you need maybe a different scanner in order to generate that digital image for you in the pathology. All of that, and then you need to think about you need to interface your lab information system with your PACS. That is the most important thing. This is what really you need. You need help when to interface your lab information with the PACS system. That is the most important one. And then from that, then you need to include your IT team. If you have some IT team from your department with the centralized IT team, so they can start communicate to see how can they build that way. So, and I don't want to go into details, but from interfacing everything through the HL7 messages between the PAC system and the lab information system.
So that's where enterprise IT is going to come in. They're going to come in when you want to interface between two systems. You have your laboratory information system. You have your PAC system. We didn't even talk about the EMR, which in a lot of cases is sort of the holy grail that everything should lead to eventually. And
Correct.
that's where you need to engage enterprise IT because they're the ones that are going to facilitate that application to application connections, right?
That is true. That is true. So the great thing right now for us, like our LIS already, because our LIS is not as the same system as the EMR. Some right now, as you know, the LIS is the same as EMR.
Uh-huh.
For example, we know Epic Pika, right?
Right, right, right.
Epic Picker for APS for CP, and then you have the Epic is also an EMR or
Right.
EHR. But some, I mean, majority of systems right now also separate of LIS from the EMR. So you need right now at this moment we only send the path reports when everything is generating in the LIS, and then we release that path report. That path report will reside or will send to the EMR for the clinicians as well as for the patients.
Mm-hmm.
So what we did, we interfaced our LIS with our PAC system.
Uh-huh.
And that's what we did right now at this moment, because our LIS is already linked to our EMR and
Okay.
only unidirectional of sending the path report to the clinicians and to the patients. But the interface with the PACS is kind of bi-directional for
Mm-hmm.
us. And we're trying to make it, build it in order right now to work in the PACS environment, but not in the LIS environment. It's a little bit tricky. They will tell you, is like, why would you do that? Why would you reinvent the wheel? I will give you one simple example. If you go right now and try to have a survey about the adoption rate for digital pathology in North America, it's not that really great, or it's not a lot of the adoption rate. And I truly believe one of these things, because most of our department still live in the LIS.
Right.
So what is your physical, what is your asset? So your assets in the beginning is the physical asset, which is the glass slide. Like
Right.
for me, I will give you a simple example. In order to get access to the lab information system, I use my glass slide, the barcode, and then use barcode scanner to access this case in the
Okay.
LIS, right?
Uh-huh.
But everything is physical. My trainee or my assistant bring all these glass slides in front of me, so it's physical. I
Right.
see. I need to have access to it. Imagine If you want to take all these physical assets and then you still want to use the same system to get access to that case, so that's why it's going to be a little bit tricky.
Because you don't have it. You don't have the
Because,
physical. Right.
yeah, they said like, okay, we're going to build it in a way in the LIS to give you some notification, but the LIS did not build for digital pathology at that time when it's built.
Right.
So you need to do a lot of, kind of either customization or things. But it's still fragmented.
Yeah.
You're not gonna get all the details and granularity about, I will tell you, when did the image distributed, how many slides distributed, okay, what is the status of the case right now? Is there any issues with the status of the case? Are there, like, for example, if there are pending images or pending slides, what are those slides that are pending and where exactly in the process? Do you
Mhm.
see these details? It's really hard sometimes to push these details back from the PAC system to the
Yeah.
LIS,
Right.
because the LIS is not interfaced with the scanner. That's another problem. So most of the, like, we call it LIS, which is Lab Information System,
Yeah.
right?
Yeah.
And in radiology, which is called Radiology Information System, which is RIS, right?
Hmm.
Right now, if you go to any radiology department, most of their scanners or CT scanner, MRI, anything, right? It's already interfaced with the lab, with their information system.
With
It's
the risks, with
with the
their information, not with the lab information
no,
system.
no, with
Right.
the so most of their scanners or their devices already interface. But right now, when you come to the digital pathology scanners and ask them that I want to interface your scanner with my LIS, nobody will say like, yes, we can build it this way.
Huh.
No, it's really, really, it's like, why do you need that? Again, because like, as you said, we're still living like in the past, that why do we need to build or interface the scanner with the LIS? I'll tell you why. Because if I interface my scanner with the lab information system and I'm using DICOM modality, all these what's called DICOM attributes, I can fill it. I can put patient name, date of birth, all the ADTs within that DICOM image from the beginning when I interface that scanner with the LIS. So when I'm gonna push that image to the PACS, that's have a full, what's called full DICOM image, not naked DICOM image.
Hmm.
So what I'm pushing right now, unfortunately, because we do not have any interface between the scanners and the LIS, what we pushing kind of naked DICOM, which means
Uh-huh.
that only DICOM that have a barcode value, so I can link the barcode value of that glass slide to the exam that PAC system received from the LIS, so they can link the
Uh-huh.
exam
Uh-huh.
to barcode value, and that image will reside in the right location.
Wow. That's a lot.
So it is a lot. It, it is a lot, and this is the only way right now, unfortunately, of linking an image. If you use a PAC system and LIS, if you want to, try to interface it, majority of these scanners, they don't do interface to pull all this information, and that's another hassle, to be honest.
Hmm.
you know
Yeah.
and most of these scanners, if they want to interface it, they don't even have DICOM. So and right now is like, my question is like, then why do you really need to bother yourself of doing interface with a scanner that does not generate a DICOM? Because to me it's useless.
Uh-huh.
I need to use all these DICOM attributes, because these DICOM attributes, imagine if I want to send it to any location, I don't need to interface with anything else. The image has a full metadata of patient information, sex, date of birth, even the anatomical site, what stain type, everything. Everything is within that image.
So there's a degree, would you say there's a degree of disconnect between the vendors and the products on the market and your actual needs?
There is, I would say that you really need to put a lot of effort and also educate the vendors about what do you need.
Mhm.
That's the other thing. When we, I mean, it's not. I mean, I'll give a credit also to the vendors because the vendors said, Dr. Yusuf, nobody asked for DICOM, and that's why seriously, and that's why we did not generate it. So I'm always like have a Dr. Clooney, David Clooney from radiology. He always say that and really I did that also in my contracts with different scanners. I said, if you right now, I understand that you don't have you don't have DICOM format, and you only have a proprietary format. But what is your plan, future plan, of having a DICOM image, or at least a DICOM converter to have a DICOM image so we can use it? And I put it in the contract,
Yeah.
literally. I'm
Uh-huh.
not judging. I put it in the contract and I say, okay, right now, it's okay to receive those in proprietary format, but after that time that you provide me your future plan, let's say after that time, if they did not fulfill their promises, I need to do data migration.
Yeah.
And all these data migration, they have to support it. They have to pay for
Right.
it, do the conversion and do everything.
So you have to be sophisticated about contracts too.
You have to be sure and you have to protect yourself. The other thing is in the contracts when you the support. Right now, there are a lot of great scanners, but you have to make sure that what type of support that you are asking for. For example, what is the service levels? You need a gold, a platinum, bronze, like, and these services, for example, how often they like if you have an issue, is it going to be serviced within 24 hours,
Mhm.
48 hours, or maybe within two
Yeah.
weeks?
Right.
Because you're doing clinical, and this is really critical.
Very good. I have we're way over time. I've kept you longer than I promised. I'm going to ask you one final question, then I'm going to let you go. What would your advice be to CIOs and CMIOs at large health systems?
Yep.
Let's say they're not currently being approached by pathology. Let's say there's no one from pathology informatics saying, "Hey, we want to do this, we want to do that." What would your advice be to the enterprise IT folks about that, how they can best support pathology? Should they be initiating any of these conversations? Should they have these meetings? How, I mean, there's a classic debate in centralized IT, which is how much do you lead and how much do you support? Where do you stand back and wait for the business, I mean, the clinicians like yourself, how much do you sit back and wait for them to initiate and then you support? Or how much do you educate yourself on the market and what's going on and the problems they're facing and bring them proactive ideas? So
Right.
what would your advice there be for
Yeah.
central IT folks?
Right. So I would say I will give you two things. From pathology, please don't be afraid of your colleague and go ahead and communicate with them because I think we did the right step by just going to them and telling them, this is, we really need your help. And they've been tremendous help for us. So that's the most important thing because they might have a solution that you don't need to reinvent the wheel. That's number one. Number two, uh, from the CMIO or CMIO, be a proactive because this is what we did. We have a lot of sister hospitals that Michigan Medicine have, and we hear that so and so they're trying to build their digital pathology. So we literally they approach them. I just told them that hey, we want to make sure that we try to help them. So they approach them. They told them, by the way, we have this and this is really, Michigan Medicine, Ann Arbor, right now, they're using this system. So why don't you just start this communication to see if this is going to work for you or not? So they reach, and but I'm the first one that I told them. I told the CMI, I was like, I hear, they're starting to uh, investigate in digital pathology, and they start the initiation and it's helped them right now. Literally, we start helping them begin the communication because imagine you have centralized solution that you can share these images, not even right now, but bringing radiology to pathology of doing computer aided diagnosis together. Like, for example, I'm a breast pathologist and we're building like some like AI or machine learning application that kind of detect, the quantify the calcifications and the radiology images versus pathology images. So there are a lot of opportunities that can help you to build kind of central image management system. So I would say it should be start from either end, to be honest.
Dr. Yousif, I can't thank you enough for your time today. I think this is going to be really helpful to a lot of the listeners. As you said, don't be afraid of pathology, right? Don't be afraid of the pathologist. It's one of the departments you need to support, and there's a lot of IT that's going on in pathology. So CIOs and CMIOs really need to engage with pathology. So thank you so much. I think what your advice is really going to help today. I really appreciate it.
Thank you, Anthony. Thank you for inviting me. I appreciate that.